will do an introduction for our speaker today.
Thank you, Dr. Licks, and welcome to the seminar. It gives me great happiness and joy to introduce Dr. Gary Teare. Dr. Teare joined the Health Quality Council in January of 2005 as the Director of Quality Management and Analysis. He is an adjunct professor in the Department of Community Health and Epidemiology and in the School of Public Health here at the university. He is an assistant professor at the University of Toronto in the Department of Health Policy, Management and Evaluation, and is an adjunct professor at the Institute for Clinical Evaluation Sciences in Toronto. At the Health Quality Council, Gary leads a team of researchers and analysts in the Council's work of measuring and reporting on the quality of healthcare in Saskatchewan and helping to develop performance measurement capabilities in the health system. As a researcher, Gary's own research has largely focused on issues of healthcare performance measurement, and he is the principal investigator of a CHIR-funded 3-year study of the impact of a nurse-led quality improvement initiative in Saskatchewan. He is also Saskatchewan's lead investigator for the Canadian Network for Observational Drug Effects Studies, a research program of the Drug Safety and Effectiveness Network of CHIR and Health Canada. This group does rapid pharmacoepidemiological analysis of prescription drugs, drug effectiveness and safety using provincial administrative health databases. Gary serves as a member of the Institutional Advisory Board of the National Accreditation Program Advisory Committee of Accreditation Canada. Dr. Teare earned a doctorate in epidemiology from the University of Guelph, a Master's of Science in immunology, at the University of Toronto, and has a professional degree as a veterinary doctor. Please welcome Gary Teare.
Thanks, Robert, and thank you, Lisa, for the invitation to come and speak at the seminar. And I must confess, my title is a little bit misleading, not entirely misleading, a little bit misleading, in that it might lead you to believe that I'm going to spend most of my time, or all of my time, talking about the research study into the evaluation of releasing time to care. And we will, in fact, spend quite a good amount of time on that. But I thought, as I was thinking through this presentation and the audience and the diversity in the audience, I thought it'd be important to begin to just talk about quality improvement in general, what it is, the science of quality improvement, and why it's important, and then get to sort of the science of studying quality improvement. So you'll have seen in the papers and some of the materials that I distributed in advance, some of the issues that are facing this field. It's a relatively new field, the field of studying quality improvement, but the field of doing quality improvement is decades and decades old. So I just want to speak very briefly about the Health Quality Council. We were established in late 2002, really opened our doors in the beginning of 2003, as a result of the FIKE Commission, which was a commission that looked at the sustainability of publicly funded healthcare in the province. And one of the key recommendations out of the FIKE Commission was that an independent quality council should be set up to help both measure and report to the public and monitor the quality of care, but also to help build capability and capacity for doing and improving the quality of care in Saskatchewan. So that's really been our mandate and mission, and our mission statement as it exists is, as you see it there, we're really here to help accelerate improvement in the province, recognizing that we partner with the health regions and the physicians and the cancer agency and the ministry and others involved in healthcare. So today what I'm going to focus on is what is quality improvement science? How does it apply to healthcare? Why is it important? And what is quality improvement research? And this is where we'll get into some of the issues around the challenges and the opportunities of this new emerging field. So quality is a problem in healthcare worldwide, and from some leading studies that published in the mid-2000s in the New England Journal of Medicine, statistics like these come forward where roughly about half of people are getting all of the evidence-based care that would be appropriate for them to receive. And so this is speaking to the problem of we know what we should be doing, the science is done, the randomized controlled trials, all the evidence is there, but somehow we don't actually get it done in practice. And what is that gap? And that's the gap that quality improvement tries to address. In a large study in 2000, and I can guarantee you issues haven't changed dramatically since, some, but not dramatically. 1 in 13 hospitalized patients in Canada experienced adverse events. And in terms of the worst types of events, it was estimated somewhere between 300 and 600 avoidable deaths happen per year in Saskatchewan. So these are deaths in hospitals that could be avoided if things didn't fall through the cracks, or not just mistakes made, but systemic problems in how we provide care. And this isn't pointing fingers at individuals so much as it is about the system in which care is provided and how that fails both patients and providers. And, essentially, comparison to other industries that we have a high level of trust in, we don't even think about crashes and death when we walk onto an airplane. At least most of us don't on a routine basis. And yet, the statistics would say that we should actually be quite concerned when we walk into a hospital or receive care. So what is quality? Well, one of the ways to define quality is to think about its dimensions. It's really a multi-dimensional concept. One of the simplest definitions of quality is that it's what the customer defines as quality. It's what the customer wants. But when you break that down, because sometimes there's things that the customer doesn't know that they need or should want. And so when you break it down into these commonly accepted dimensions, it's aspects of safety. So the types of things we were just talking about, ensuring that when people come in, they can truly assume that the care that they will be receiving is safe. Effectiveness speaks to evidence-based or evidence-informed practice, doing what the science we know tells us we should be doing, and having the impacts that we want to have with healthcare interventions. Patient-centeredness is probably, if you had to elevate one of these over the others as a key priority, this would probably be the one. And in this province, ever since our patient first review, it has really been a strong focus. The healthcare system, by and large, is designed really to meet the needs and the schedules and the needs of the system that provides the care, more so currently than it is designed around specifically what the patients would need and want, and make their experience, both more pleasant and of high quality in their opinion. So patient-centeredness is a big emphasis in our healthcare system now in terms of trying to understand what that means and redevelop our culture of care. Timeliness, so another big attention focus in our province right now, really key around the surgical wait times. One of the things that came out of the patient's first review was people were tired of waiting 12 and 18 months to get their hips or knees or other surgeries done. And so there's been a large focus placed on how can we tackle the problem of wait times in the province. And then efficiency and equity, these being, efficiency being paying attention to the cost side. So we can't just continue to throw lots of extra money into the health system, both to try to improve it and to expand its capacity. And we also have to pay attention to equity. We can't just focus our improvements where they're easiest to do, but we have populations in this province, in this city, and different segments of the populations that need special attention in terms of access or quality or patient-centeredness and that sort of thing. So all of those dimensions go together to comprise what we think of as quality, and interventions and quality improvement efforts need to focus on multiple of those. So a simple definition that the Agency for Healthcare Research and Quality has put out for what is quality in healthcare means doing the right thing at the right time in the right way for the right person with the best possible outcome. So you can see the dimensions of quality reflected in those words that they've put into the definition. So in healthcare and in healthcare research, we've spent a lot of money and time focusing on doing the right thing, creating the evidence base for what is the right work that we should, what is the right intervention. We've put a lot of effort into biotech to create vaccines or create new medications or that sort of thing. Pharmacology and pharmacotherapeutics to design appropriate drugs for old diseases and new ones, and refining treatments for diseases that have been around for a long time. Diagnostics, new types of imaging, new types of immunological-based tests that we can do at the bedside as opposed to having to send them to the lab. All kinds of innovations that we've been doing on the doing the right thing side. And really, this is where our money has by and large focused in healthcare research. And yet, that quality gap, that quality chasm remains. And it speaks to an issue of needing to think about more than just understanding what the right thing is to do, but also how to do the right thing. So why is this? Well, one of the problems we face in healthcare delivery and as healthcare providers and managers in the system is that we have an exploding literature, an exploding knowledge base, and there's as an internist in a hospital, you would have to be keeping up with a phenomenal amount of literature each month just to keep current in your field if you were really to take this seriously. Now, we tend to have things like the Cochrane Review and other processes for condensing clinical practice guidelines, that sort of thing. But the fact remains that we're exploding on this innovation and discovery of the right thing to do side, and we haven't figured out yet how to bring that forward into practice. So is this an impossible task? Even when we know what the right thing to do, evidence suggests that it takes somewhere between 15 and 20 years often for a majority of people to get care from the time an innovation is discovered or proven to be effective to when a majority of people will actually receive that intervention in their care. Now, this isn't uniform. Some interventions jump the queue and get right into practice very quickly. So, arthroscopic surgeries for cholecystectomies, for gallbladder surgeries. Man, as soon as that was discovered, that really spread rapidly. And so there's a lot of issues around the innovation itself, but how it fits with the culture and the incentives and the interests of the healthcare providers and the healthcare system. That determines this time frame of going from basically discovery of the evidence to practice. But by and large, we face this type of a gap, and in the meantime, while we're waiting for that practice to change, we're suffering issues of overuse, underuse, and misuse. So we have clear overuse of some diagnostic imaging modalities. We have clear overuse of some surgical modalities. These are areas that are not readily measured and readily evaluated with our current data systems, but we can begin to look at these things in ways that have been done in the States and elsewhere. But there's also issues of underuse. There's issues of knowing that there's a set of 4 drugs that people after their heart attack should be considered for, and most people should be on those 3 or 4 drugs, and yet our current record in this is we're somewhere in the 60 to 70% range of getting that done. And then, of course, there's misuse, things where just the wrong thing is being done. So when you think about this translation of evidence into practice, a simple model might be illustrated like this. We establish the basic biomedical knowledge. We do clinical studies to translate the basic biochemistry or pharmacology into how would that work out in actual treatment of people. And then based on that, you establish a clinical knowledge base and you diffuse it and it gets into practice. And that's sort of the Pollyanna view and quite literally the view that until they got some feedback and so on that CIHR was taking for the strategy for patient-oriented research. And yet, when you look at the real world, there are several blocks along the way that occur. The initial block, of course, being just getting from basic evidence into clinical trials. There's a whole, getting people interested, getting the grant funding to make it happen, that sort of thing. But then the next stage, when you've done the clinical trials or the clinical studies, to come up to a place where it's an established set of clinical knowledge, the key problem there is coming to consensus. And often this is done through clinical practice guidelines, through expert groups, and dissemination of that sort of information. And then there's a further block then once the information is established, and this is sort of at the 15 to 20 year mark before you see it widely in practice, there's another block. And the key problem here is that people have to change. And that is a much bigger problem than we face in the previous two blocks, because that's speaking about behavior change, just like smoking cessation or drug abuse or these sorts of things. I mean, these are human behaviors that require a lot of work and different methodologies than we've typically been used to. So what I'm saying, I guess, is that we need to focus on the right way, but we also need to focus at the right time and for the right person. And these are aspects to which health services research and then quality improvement research can contribute. And taking this focus requires innovation in delivery models. So how we deliver care, how we set up our primary care practice system, how we support that primary care practice system with information technology and management and other types of support, so that you get away from the lone cowboy doctor out in their practice in the boondocks, but they have some kind of support network built around them to help them to understand and make doing the right thing the easy thing to do. So system redesign, reliability. We need to learn from the safety and reliability science that's used in industry and in the airline industry to build in reliability to our care. So one key element that's being done in Saskatchewan around this is the surgical checklist. Very simple technology of having surgical teams stop and go through a checklist, just like a pilot in an airplane would go through, a pilot and the crew in the airplane would go through a checklist to figure out, have they done all the checks? Have they checked that there's fuel in both tanks, that the flaps all work, and that sort of thing. And the environment in that team to allow anyone to stop the line at any time if things aren't right before you proceed. So, and then issues of knowledge translation. We need to innovate in the ways and means we both do and understand how to do the translation of knowledge from clinical practice guidelines or established evidence into changing behavior. So overcoming the third translational block involves quality improvement. And what is quality improvement? Well, it's a range of strategies and techniques designed to improve performance and quality across systems. So, and the across systems is highlighted there because in quality improvement, we're not so much focused on the individual's contribution to quality, although that's important. We're really focused on the system within which the individual does their work and how that enables or disables doing the right thing for the right person at the right time. Now, there's lots of different terminology and words. It's a whole new language when you start to get into this world. And in fact, there are branches of quality improvement science that until more recently haven't really spoken with each other. And we're, in the province now, in the healthcare system, we are learning some of those different languages. Some of them are Japanese, and some of them are business knowledge language, and some of them are industrial. But a key element to quality improvement science is that we need to think about systems. We need to look beneath the events of the everyday. So it's not about just the error that happened or the adverse event. It's important to capture that as a signal to whether things are bad or whether things are getting better. But it's important to do more than just the drill down on that individual event, to understand the system of inputs, both providers, the equipment, the processes of care, and the patient involvement that underlies those adverse events. So it's pretty key that we understand healthcare and delivering care as a system. And then we need to understand another key element of quality improvement is understanding variation. So understanding the system and knowing how the different bits and pieces work together is one piece. And then the other is to be actually able to measure the process and measure the outcomes of care and look at the variation in that over time and ultimately both reduce that variation to a standard amount and then increase the quality towards targets or the desired performance. So in science, typically, we're used to looking at data from a static view where we do our survey or we take our administrative data and we look at it as a pool of data. And we look at variation in that data, but it's within that sample frame that we've looked at within that specific period of time. But it's important for quality improvement that we actually kind of turn that on its side and begin to look at the dynamic view of data. So one person has talked about this as the difference between sampling from a pond and sampling from a river. So if you think about healthcare as an ongoing process that is dynamic, there are elements of it that are unchanging from day to day, and there are random elements that will change from day to day, the types and severity of the patients, the particular clinicians that are on at the time, and those sorts of things. And what in healthcare quality we do is we sample from that river over time, and then we look at the variation over time as opposed to just looking within a fixed sample taken on a given day or month or year. And the key elements here is that we look for two kinds of variation. One being common cause, or essentially the noise in the system that exists just because of the performance of the system itself, and both the how we measure and how the system performs over time. And then we look at special cause variation, which is sort of assignable variation. This is where things get unexpected. You get unexpected variation. And in a view using control charts or run charts, but particularly control charts, which come out of quality and process engineering, you look for, there's a set of rules where you look for extreme values or values that are going all in one direction over a certain number of data points, or sitting on one side of the median or the mean for a period of time. So it's a branch of statistics that we don't typically learn about in school, except maybe if you were in engineering. You might learn about these analytic methods of analysis. In this branch of parametric statistics, looking at dynamic time series through statistical process control and related types of techniques are called analytic methods, and the more classical experimental based, analysis of variation and all the types of things that we typically learn in school are classified as enumerative methods of analysis. And they each have their uses, where analytic methods are particularly sensitive to and good for predicting what is likely to happen in the near future based on what's been happening in the recent past. So this is a control chart, and I won't go into all the details of this, but this is widely used and heavily used in healthcare. And so we're, at the Health Quality Council, we're trying to move measurement of the health system in this direction, and I'll show you a website that you can visit later that has measurements like it on this. But essentially what you've got here is a measurement of third next available appointment at a clinic. So this is a measure of the time until the third next available appointment in a doctor's clinic, and it's the most widely accepted measure for access to care in clinical medicine. And an intervention has been ongoing in this particular clinic, and you can see very distinctly after December that there was a shift downward in the performance of this system, and it clearly shows up, and that's one of the key strengths of this type of analysis, is that these changes show up fairly quickly, much more quickly than if you were just doing pre and post, where you have to wait till the end of some given time period. And the idea here is that you're sampling constantly, preferably daily, weekly, or monthly. Getting out beyond monthly, it becomes less timely for interaction. And then you'll see the little lines above and below, the little red dashed lines, and these are upper and lower control limits. They're not confidence limits. They're calculated in a different way, but they enable you to get a sense of what is the kind of normal variation in this system, that unassignable, the variation that just comes from the operation of the system. And if points lie outside of that point, or if indeed they shift below the line or above the line, or trend in a given direction over a number of data points in a row, those gives you the signals that things have changed. So Saskatchewan's been on a quality journey. We like to think accelerated since the initiation of the Health Quality Council and the work that we've been doing with the regions and the Cancer Agency. Our work is measuring and reporting on quality of healthcare, working with health system partners to promote and support quality improvement learning. So we do a lot of training, both at the advanced levels and at basic levels, both through the quality initiatives that we run in collaboration with healthcare providers, as well as in more formal learning settings like our Quality Improvement Consultant School. And we've also done work with the university to train students or teach students and faculty members about quality improvement science. And more recently, we are one of the partners in establishing a quality improvement science chair here at the university that is sort of now in a recruitment stage to try to really build a bit of a center, a bit of a focal point for quality improvement science at the academic level. Health Quality Council has been involved in a lot of what you might think of as health services research, and as really meeting our function of trying to report on the quality of healthcare in the province. We've produced a number of reports that we post on our website to inform the healthcare system, but we also publish articles in the peer review literature based on research that we do at the Health Quality Council. And this is the website that I was telling you about, where currently we are reporting in a public fashion the key metrics that the health system is following around some of the priority improvement areas that they're working on. So, I don't know how much you'll be able to read there, but there are quite a few indicators that you can browse on this. There's sort of 3 main pages, and when you click on each of those little spark graphs, it takes you to the bigger control chart or run chart underneath, and you can drill down to the hospital level for some of these, or the region level. Depends on what level we have the data. Some are available on a monthly level basis, some are available on a quarterly basis, occasionally available only on an annual level because it's based on surveys that are done annually. So if you want to look that up at some point, you can easily find it at www.qualityinsight.ca, and it's part of our mandate to help make the health system transparent, but really this is designed to be primarily used and useful to leaders of the healthcare system so that they can, in one place, find the metrics that they need to be following for appropriately leading the quality improvement journey that Saskatchewan's on. Health Quality Council has been really trying to intervene in organizational improvement capability, so building organizations like the regions and doctors' offices and cancer agencies' ability to do quality improvement. We've been working on measurement infrastructure, so the Quality Insight Online that I was showing you is part of that. We've been working with leaders through a leadership training collaborative that ended, was that, Kyla, about a year ago or so, and has led to a number of new initiatives that are that the health system are coming together on at leadership level. And then clinician engagement work, where we're actually working directly with clinicians in hospitals and primary care to help them understand QI science and get engaged. And releasing time to care was one of those engagement, clinician engagement things. But one of the interesting questions is, does QI work? I mean, there's a literature out there that has looked at QI from an experimental point of view and tried to demonstrate efficacy or not, and it can be quite mixed in the experimental approaches. I just want to take you back to the research journey towards high-quality healthcare. Going from the basic biomedical science to the clinical efficacy knowledge, you have to test what care works. So that's your basic clinical trial type of work. To go from the clinical efficacy knowledge to clinical effectiveness, you have to find out who does it work for, and does it actually work in sort of real life settings? And this is where things like comparative effectiveness research, or what we typically think of around health services research, tends to fit. And then the third translational block, and this was in that one of those articles I gave you, speaks to the block between knowing the effectiveness and getting it actually integrated into care. And this is where we need to test how to deliver high quality care reliably and in all settings. So this speaks to the whole area of quality improvement science, where we're trying to do things like measure and monitor for accountability and improvement purposes, like we're doing with Quality Insight Online, but also implementing interventions in different settings and understanding what it is about those settings that helps them to work or not work. Because these are no longer simple interventions. They're often complex interventions that involve multiple things that need to work in harmony to have the impact. And you need to know why in some settings does that work and not as well in others, and understand that piece of it. So we end up in a research dilemma because our paradigm in science has been the experimental model. And our paradigm has been a ranking of evidence from randomized controlled trial on the top to case series on the bottom, and various observational sciences or approaches in between. And yet when we look at what we're trying to study in quality improvement science, the complexity of it is such that we actually don't want to control out the confounders, or the elements that actually describe and illustrate the context in which we're trying to study the intervention. So, a statement about quality improvement collaboratives, which are large, multi-organization learning processes over the course of usually a year, year and a half, where they do quality improvement, they come together to learn from each other, they go back, they do it some more, they come back, they learn from each other. The evidence on the effectiveness of these is mixed. And when you look at them in a sort of a randomized controlled trial review. However, as David Off and others have clearly articulated, healthcare improvement is a social discipline. It actually doesn't lend itself very well to strict experimental methodology to understand it, because it's as much about change in human behavior and understanding human behavior and how that changes over time as it is a clinical discipline. So the methodologies that we apply in the clinical effectiveness world, and somewhat in the world of going from effectiveness to, or from efficacy to effectiveness, are helpful, but not sufficient in the understanding what makes QI work or not. So if you think about it, quality improvement, the science that and the statistical methodology and the study methodology, the experimental methodology that we've developed has really focused on discrete interventions that can be isolated from other factors, like a drug therapy. However, traditional biomedical or experimental research models, I'm arguing, are not sufficient, and when we use them exclusively to evaluate QI science, we're actually trying to drive a square peg into a round hole, I think. This is the sort of the background of classical experimental research, and this is what we face in doing quality improvement science when we're trying to go from what works in an experimental setting to what works in the real world. And it's actually understanding the context is at least more than half the game when we're doing quality improvement research. So this is by definition a multidisciplinary, multi-method approach that we need to take. And there are quantitative and qualitative and mixed methods, mixtures of those that we need to take it. So I spoke to you before about some of the ways that Health Quality Council is trying to intervene in the system. One of them being this releasing time to care intervention. We knew from hearing from nurses, both nationally and within the province, that nurses felt that their team had given poor or fair care on, at least 13% of nurses said that in nursing surveys, that a number felt that they had given poor care, and this was the second highest of all provinces. So there was an issue of feeling among nurses themselves that there was an issue in the care they were providing. 32% reported that patients were injured in falls, and we have a very high injury and fall hospitalization rate in this province, not just from within hospital and within care, but generally. We have high numbers feeling there's too much work on their plates for one person to deal with, healthcare providers and nurses in particular. Nearly half saying they don't have enough time to do all the things that they need to do to provide good care in the day, and quite a significant number reporting job strain. So our typical approach in healthcare and in the politics of healthcare is to throw money at the system and hope that the problem will go away. Hiring more nurses, providing better salaries, trying to provide more resources to get the job done. However, we need to ask ourselves, is that the only way in an environment where costs of healthcare are accelerating at multiples and much more rapidly than either inflation or the GDP? So releasing time to care is a intervention in a box, you might say, that was developed by the National Health Service Institute for Innovation in Britain. And really what they took is a quality improvement methodologies that were pioneered in Japanese manufacturing, Toyota being one of the key ones, and took the Japanese language out and took the industrial concepts out and translated it into nursing language and processes that nurses would understand and would be able to relate to, and then made it modular so that, because we all recognize that you can't have enough quality improvement consultants or people around to handhold teams through projects. They can't be there all the time and with every team if you're trying to spread this widely. So they actually boxed it and put it in a modular way so that the team could take control of this work themselves and do it, and not be feeling like they're just doing work for the quality department of the hospital or whatever. So the aim was to improve patient outcomes and overall job satisfaction, and to try to do more and do better within the same amount of resources. So not seeking to improve or increase the amount of resources, but rather increase the effectiveness. So the principle of releasing time to care is that there's a total time spent in a nurse's day, and if you can ensure that their motion, their running around, is reduced by having things that they need in logical places so that they don't need to move around as much to get the equipment or the materials that they need to provide care. If their paperwork is simplified so that it's easy to understand, quick to complete. If their discussions are not interrupted, or their work around medication delivery is not interrupted, they don't have the distractions and don't have to multitask, so they can get things done in less time in that way. If handovers are more concise and timely and provide all the information they need so they don't have to be looking it up in the chart all the time. And when it's clear that everyone knows what their role is and what they're responsible for, all of these things can save little bits of time that accumulate to enable less waste of time and create an opportunity for more time for the nurse to spend in providing direct care with the patient, where they have an opportunity to speak with the patient more, provide services around that will make their care more safe and reliable, and in fact increase the patient experience of care, because they're actually able to interface and have a human relationship with the nurse more during the day. These are the general aims, and there's measures attached to those that are sort of outlined in the package of releasing time to care. And the program comes with a number of modules where they work through them one by one. There's sort of 3 foundational modules that they go through to really understand what they're doing, and helping to clean up spaces in their ward so that they can get some of those early wins about saving time and motion and hunting for things. And then they can take their own lead in terms of which of the other modules they work their way through in which order. And the language is built in a standard type of language that nurses will learn in nursing school in terms of how they approach it. Each cycle through the module will go through an improvement and a work cycle that it would be very familiar with nurse work patterns. So one of the early modules they do is well-organized ward, or WOW, and this is where it's actually one of those quick wins, one of those early things that they see, hey, this is really making a difference in my day. So this is a main storage room in one of the nursing units on one of our hospitals in the province. Before they applied 5S. I'm not going to get into what all the 5S's are, but essentially it's a methodology that's, again, taken from industry about cleaning up, organizing, and then creating a system that keeps it that way through visual cues. And after they did their 5S, that's what their room looked like. So you can understand, you can think about your own workshop or your own garage or something like it. It all applies in our daily lives as well as in our work lives. But the nurse that walks into this room will be able to go directly to find what she or he needs without hunting through the mess. And so that saves time that can be then applied to doing quality improvement work, spending more time with the patient. Likewise, there's a spaghetti diagram, sort of pre and post, where they relocated some equipment so that the nurse didn't have to run down the hall all the time to get it. It was closer to the rooms where that equipment would be used. And they figured they saved about 13 minutes a shift, or 158 hours a year, or basically 13 nursing shifts per year. So you start to free up real amounts of time when you apply this methodology. And they use a lot of visual cues. You'll see this if you go on hospital wards that are doing RTC now. They've got performance metrics and how we're doing up on the board in the unit, so the families can see it, the patients can see it, but very importantly, the nurses and the team on the unit can see how they're doing. And so this is called a safety cross, and they basically, if it's got a red square in it on a particular day in the month, it indicates a fall or one of the adverse events, in this case an infection. And that helps to highlight when they do their daily review at the board, they call them board meetings because it's at the board, they can identify what's happening and resolve that issue quickly rather than it just going in someone's documentation and taking time to be resolved. So these are what some of these releasing time to care boards look like in wards, and this in itself is an innovation and a dramatic change to how care is delivered. There's been excellent support for this from the Union of Nurses, which is really key because anytime you do change behavior and patterns of work and so on, you want to make sure your unions are on board, and they're really supportive of this because of the empowerment and the control that it puts in the hands of the nurses to shape and improve their own daily work. And our Minister of Health, you can see there on the right in the picture, and the Deputy Minister beside him, have made conscious effort to visit many of these wards, some more than once, Kyla, to re-emphasize how important this thing is in the work. So it speaks to the importance of leadership visits and leadership engagement. So it's happening all across the province. Ultimately, all surgical and medical wards and will be engaged in using releasing time to care, and it's also infiltrating mental health wards and pediatric wards, etc. So our question was, does it work? Because when we pulled this from the National Health Service, there was no, there was anecdotal evidence, there was an evaluation ongoing, but there wasn't sort of evidence, you know, that it works. And so UK sites certainly were identifying that it was reducing interruptions, that it was allowing them to develop and maintain important safety processes. They had increases in the direct care time, as was predicted, decreases in sick rates. And in the early wards that we trialed it on in the province, anecdotally, nurses were saying they loved it, that it was really feeling like the right thing to do. But we wanted to actually study the impacts. So we did write a CIHR FISI, or Partnerships for Health Services Improvement Grant, and we got a great award from CIHR and matched with, or partnered with SHRF. The 2.9 million is actually, over half of that is partnership from the Union of Nurses and Government partnership, where they've got designated money for hiring nurses. And they really initiated with us in the early planning of this intervention some particular nurses that would be focused on the issues of measurement, quality measurement at the unit, at the microsystem, the level of where patient care happens. We're very used to measurement happening in the, you know, at the senior leadership level and quality councils and CIHI and others reporting, but not enough attention and not enough support has been provided at the level of what happens in the day-to-day interface with patients. So really key support to this intervention was that there were nursing measurement coordinators. This is the research team. Basically, mostly U of S, some from other universities. Significantly, we were able to involve some UK researchers that had been involved in evaluating releasing time to care in the UK. And then decision-making partners. So important in the FISI grants is that decision-making partners are part of the team and actively involved in determining the research questions and the work that gets done. We conceptualized our work as an interactive research model where you've got the research team, the research system that does their own learning through the process of doing this research, but you've also got the practice system, those leaders as well as the nurses and the people at the front line that are learning about how to do this and about its impact over time as well. So, for the sake of time, I won't dwell on this, but the idea was to try to bring these two worlds together through this research study to enable the learning to be magnified for both groups over time. So an early meeting that we had to design the research involving both decision makers and researchers. Together then, we determined through this interaction what the research questions would be, designed what the research design would be like, which is essentially a combination of using administrative data that's already available in the system, because we were very conscious that the nurses' focus would be on doing the improvement and the local measurement that they need to do. So we didn't want to pile on a lot of extra measurement that would take away from the important work of focusing on learning how to do the improvement. So we used administrative data. We used selective surveys, particularly around the nurse and unit environment that we wanted to measure. And then we'll have case studies, qualitative studies in the through the course of the research to really get at some of the context questions. These were the research questions, so trying to understand the impacts on the unit, trying to understand the contextual factors that some of these would be leadership, involvement, and these sorts of things, and what are the impacts of RTC on patient outcomes, ultimately, because that's the big so what. This was our sort of model of what this looked like. So the theory was that releasing time to care would impact on two things in the unit environment. It would increase efficiencies through changes in the physical environment, improving local measurements so they would understand how they're doing, and improving work processes, but it also improved staff well-being from a number of reasons, but importantly from their engagement in this work and their feeling of empowerment that they are actually running this show in terms of the improvement they're doing. And then ultimately that those improvements in the unit environment would translate into patient outcomes, measured both in terms of patient experience, their subjective experience of the care they receive, as well as patient safety and reliability. So these are the fleshing that out into what we actually use to measure, but suffice to say, our patient outcomes are thin because we don't have a lot of really good data in the system right now that's captured on a routine basis in hospitals. So we're mining the discharge abstract data for all it's worth. We're looking at length of stay, which you would hypothesize and has been shown in the UK to be impacted and reduced where care becomes more efficient and more focus is spent on being able to provide more care directly at the bedside. We were looking at readmissions in terms of another effectiveness and safety outcome, and then we're looking at falls as well to the extent that we can, although there's a small number of issues with that outcome. But a lot of focus, because we feel the direct and most important impact of releasing time to care will be in the staff empowerment and the work environment. So a lot of attention there. This was our data collection plan that we submitted, but basically it's a time series that we're looking at, and we propose to do interrupted time series analysis. So, if you can't do an experimental study, then interrupted time series is your next best bet, because it's a very strong way of taking out some of the time effects that could impact your interpretation of changes over time. And basically, we plotted out the monthly data, the quarterly data, and the periodic data that we'd be able to get based on data that's available and data that we'd be purposely collecting. One of them was, obviously, the title of the thing is Releasing Time to Care. So we wanted to be able to measure direct care time and indirect care time and understand how that changes with this intervention. The theory being that you should release more time for direct care. To do this, we used personal digital assistants the nurses would use, and it's a sampling methodology whereby they have these and they carry them for a week, a month, and it basically beeps at them on the average, about every 26 minutes, but it's randomly, the time is randomly assigned through the day. And I basically asked them, where were you last, what are you doing now, and where are you going next, sort of thing. And it gets at, it's a way of, in a sampling modality, doing a time and motion study, essentially, without having someone have to follow someone around all the time. It's self-collected by the nurses, and we've had some fun and games with this thing in terms of technological issues, but and just acceptance of technology at the front line. But by and large, it's been a reasonably successful approach to collecting data, and has really, very interestingly, shown up some of the challenges we face at the front line in measuring anything on an ongoing basis in the day-to-day. And some of our issues with this measurement, I think, are just reflecting some of those issues of we're not used to, as healthcare providers, collecting data about what we do. And so the learnings just in doing this have been fascinating and will be really interesting in terms of what we do with electronic medical records and other approaches. So on the PDA, there are different categories of time based on what the nurse clicks on, what they were doing, and so on. And these are classified into value-added activities, so things that the patient themselves would say they feel adds direct value to their care. And those are direct care and indirect care types of activities. And then necessary activities, so things that you need to do, but the patient wouldn't really recognize as adding value to their care or their experience in the hospital. And then non-value-added activities, which are personal time and waste. Waste being the piece of the excess running around, the hunting for things, the administrative waste that we build into the system by not thinking of a system and organizing it. Now, this is the data that we're getting. And this is just one example, but of value-added time. And you can see we got a flat line happening here. Even though the intervention has been in place here since really early on in that time series. So, wow, it's not releasing time to care. But, now when we, sort of get over our initial shock and say, oh, well, this isn't working the way we thought it would, we've gone back and begun to understand, well, why is that? What is that telling us? And part of the issue here is that, we think at least, is that there was really no, even though the program is called Releasing Time to Care and people sort of subjectively buy into that being an important outcome of it, there really hasn't been any goals set about what are we trying to, how much time are we trying to release, over what time period. And when you set goals and make it a priority, then you start to engage with that work and really put direct effort into trying to impact that measure. And that really hasn't happened to date in the rollout of, at least on a widespread level, in the rollout of Releasing Time to Care. So that's a learning in terms of nurses have been doing a lot of excellent learning around the process, around understanding their processes, around reorganizing their wards and that sort of thing. But they haven't necessarily focused on, are we increasing value-added time through this work that we're doing? But the plus side of this is, had we not been using the PDAs, we wouldn't have known this. And they wouldn't have known this. And so it gives them now pause to think, okay, so how important is this outcome, and do we want to do something about this? The other side of this, when we talk with folks that do this in the States and benchmark across hospitals in the States, they say, this isn't necessarily a bad outcome either, because it's also a bit of a, kind of a control measure or a monitoring your system measure. All the improvement work you're doing, which might take people away from providing care because they're doing things like organizing their storeroom and taking doors out and reconfiguring their meetings, at least we know that it hasn't taken time away from patients. So at least we've got that level of assurance in the data. So yeah, it's not what we expected, but we're learning things from it even so. And then this just shows sort of across the various wards that really the pattern is the same. So it's not that the aggregate one is hiding a lot of variation. They're actually flatlining across the board. And so, this raises some questions for us going forward as to do we need to pay some more attention to this measure and this as a goal in the Releasing Time to Care. We do surveys, 3 standardized and well-documented nursing surveys. Basically, from our baseline data, because we're just in the process of collecting follow-up data now for some of the wards, our baseline data was looking very much like published data used, reported for wards in Canadian hospitals. So we're pretty confident that the data collection process is going well and that the numbers are coming in as expected. Likewise, with the Maslach spread-out inventory, our numbers are very closely match what was found in cross-sectional surveys of nurses in Canadian hospital wards. An impact on staff well-being, some of the administrative data we're getting is data that's collected by SAHO through the, basically the data that's used for payroll and so on, and we can access data around sick time, overtime, and voluntary staff turnover, so that we'll be able to use these to say, is the program impacting some of these staff well-being indicators? Remember, the second research question, and a large part of what's important in quality improvement research, is understanding the context in which the intervention does or doesn't work. And really, to get at this, we are going to be undertaking at least 4, maybe 6 in-depth case studies to look at things like compositions of unit staff, the involvement of leadership, elements of organizational culture that might be important here, and other key barriers and facilitators. And our original idea was that we would, when you do case studies, you'd like to do extreme groups so you can actually detect some differences. And our original idea was we'd use the direct care time changes, Well, we saw that's not going to work for us because that one's kind of flat. So we went back to the drawing board on that one, and this is the real life nature of QI research that where the intervention is actually not tightly in your control. And we looked at based on theory, some of the elements of the context that might result in greater success in implementing and having outcomes from the releasing time to care. And some of the key ones that popped up were module fidelity. So are they using the modules and getting through them, completing the various tasks and learning the pieces they need to learn through the modules? How engaged is the leadership? There needs to be engagement at the ward level, at the department level, or the program level, and at the senior management level. And each of these levels, there is a role for them to be visiting and engaged with the individual units in their work. So how is that happening? And then the direct care time, which I told you didn't help us too much in this case. And also considerations of rural and urban, because large and small and those different environments could have an impact. So just to show you how we, based on judgments provided by the coaches to these teams as to where the different unit teams were at in some of these dimensions of context that we were thinking would be important. The two really important ones that sort of jumped out being leadership and module fidelity. We've got a bit of a spread, and so based on that, we can select, some more extreme groups to do our case studies with, and we're now in the process of designing what those case studies will look like. What will the key questions be? Who will we interview? And those sorts of things. What kind of documents and evidence will we want to gather? And finally, research question 3, patient outcomes. We have 3 approaches to collecting data here. There's a patient experience survey that's been ongoing on a continuous basis in Saskatchewan on a monthly or bi-weekly basis, really, since 2007. So we've got a great time series of data there to tap into. We'll be looking at length of stay and readmissions. And this is the data from one hospital over time in the patient experience survey. One question being patients' response to the question, do nurses always explain things clearly? So this would be one outcome that we could see might, in fact, respond to the releasing time to care intervention if nurses, in fact, are able to spend more time with patients and do more teaching and instruction. So we're not seeing a whole lot of movement yet, but this is one that we're still just in the midst of rolling out the intervention. So this will be one of the indicators we'll be tracking over time. So with that, I'll just conclude by saying it's been a delight to be able to present this to you, and I hope it stimulated some thoughts and some questions that you might want to discuss.
Thank you, Dr. Teare, for a great talk, and I'd like to open up the floor to some questions from the audience. Oh, let's start in Regina, yes. How do we do that? Oh, great. I should probably stand over here so I'm in the screen.
Moderate.
Yeah. So are there any questions in Regina? Can you hear me there?
Go ahead, Saskatoon. I think there'll be a few questions later.
Okay, so we'll turn the floor to people here in our audience. Are there any questions for Dr. Teare?
Which one? Yeah, those would be monthly. Okay, sorry, yeah, the question was, what was the time period or the time cycle for measurement? And for this is the PDA data, the personal digital assistant data for care time, and it was monthly. So collected using a sampling approach of 1 week out of the month, and nurses over the course of shifts in that week. We seem to be getting a lot of feedback from the Regina site. I'm not sure if you need to mute or... Oh, okay. Any other questions? Or I can repeat it if you want. Yeah. So I'll take you back to there. So in the element of understanding the unit environment as an outcome, it's actually also a intermediate variable towards patient outcomes, but as an outcome itself, we're looking at staff satisfaction. So we're not actually doing staff satisfaction measurement ourselves, but the various wards are doing their own in the context of their work. And then we have added specific surveys. So I've got them listed here. A team climate survey in healthcare, which gets at interactions and really the functioning of the team. The conditions of workplace effectiveness, which speaks to their opportunity for impacting their work and growing in their work, the information that they have accessible to them, the support that they feel in their work, the resources that they have available to them, and then it has scales around formal power, informal power, and a global empowerment scale. So these get at really their sense of the conditions for their effectiveness in their work. And then the last survey was the Maslach-Burnoff survey, which really gets at issues of exhaustion, cynicism, and efficacy. So essentially, are you feeling overwhelmed in your work? Do you feel like you can be effective in your work? Are you feeling positive about your work? That would be ways of translating that. So those are the measures we're gathering through the surveys of nurses, and we do that at 3 time intervals: pre-implementation, sort of mid-implementation, then after, and then we're planning on doing a post-post as well, so that we can get a bit better time series there. And then the other ones being the stuff that we're doing using the administrative data from SEHO to get at sick time, overtime, and staff turnover. So how we're trying to cover off those the workplace environment changes that would come about, because we feel this is actually probably the strongest impact. The patient impacts will be much more indirect and probably lagged in coming, so these are the ones we're most likely to detect in the first couple of years. Yeah. So the sick time, overtime, and this stuff is monthly because it's based on the payroll data. And then the surveys are at 4 time periods over the course of the intervention. And we do that for each wave, because this is actually rolling out in different waves. So there's a wave 1, wave 2, a wave 3 for a cycle. And we do that same process for at least the first 3 waves. We'll still have money in the 3-year cycle of the grant to do. So.
Any other question from Regina?
Oh yeah, sure. Let's let's do a question from Regina and then we'll come back.
Thank you. Gary, can you just describe how you are reporting your research results to your decision-making partners, including SUN and the Ministry of Health, and what has been their reaction so far to those results?
Yeah. So our research meeting that we had in November, we were kind of pre-results. We were just getting early results from our handheld devices for the direct care time. And most of our results, as you can see, are still coming. So we haven't done a formal feedback to all the partners yet, but we've got a newsletter that we'll be putting out in the next month to begin to bring them some of these highlights of some of the issues that we're coming up against and some of the early findings that we're seeing, as I've been sharing with you. So, but apart from the research study, the actual implementation process does on a quarterly basis. They do a, what do you call it, Kyla? It's the CASTLE report, right? I'm going to forget what CASTLE means. Yeah. So it's a quarterly report that gets done to the ministry from all the different regions, and it basically tells the story of how the units and the health regions are progressing in the rollout of this intervention. And so there has been increasing quantitative run chart data in those reports where they're reporting on their own. Some of them are actually doing their own in-facility patient experience surveys, sort of within the unit, or they're doing their staff engagement or satisfaction surveys and measures of some of the safety outcomes and things like that that they're trying to impact on. So that kind of feedback has been coming all along to the government, and my understanding is that so far everyone's still very excited and engaged and sees this as a pretty key quality initiative in our province. And it's on what we call the SOD, or the Strategic Operational Directions in the health system, which is really the expression of the strategic plan for the health system for the current year. Does that answer your question?
Thank you.
Hi, I'm Beverly Belaski, a registered nurse. I've just recently been employed with the Saskatchewan Union of Nurses, so I can't certainly comment on a lot of what the organization has been doing. But my understanding of releasing time to care is that many of the facilities have done the first module, which is the well-organized workplace. Where are the other sites starting on the other modules, and do you think that will impact your results?
Yeah, really interesting question. And it reflects that when you do quality improvement science, quality improvement research in the real world, you're a bit like a movie director and a filmer. You're standing back watching the thing unfold in front of you, and in fact, you're even less in control of it than the person shooting the film, because you can't actually tell the players what they should be doing and how they should be doing it. But we're right now, we've essentially completed cycle 1, is my understanding, right, Carla? Keep going to Carla because she's actually the manager. Yeah, the first 4 modules. So the first 4 modules, pretty much all of the cycle 1 group has gotten through at this point, and cycle 2 is working their way through, and cycle 3 is just starting. So yes, we don't have a whole lot of results to show yet because the whole thing is just getting going, and we wouldn't predict. But we are starting to see in that cycle 1 some changes in our survey measures, but the surveys are still coming in, so I wasn't prepared to show them yet. But we're beginning to see those changes, so that's encouraging because that's where we thought we'd see the changes first. The other interesting thing is that it's again nothing like experimental science. The intervention is some of these wards are actually going back and redoing some of these modules, because as they go through them, they're recognizing we thought we checked that one off, but as we move ahead, we understand that we didn't really understand it as well as we thought we did. So we're going to go back and we're going to revisit that one around how we do measurement or how we understand the system and so on. So I'd say you're bang on that, you know, things are still in early days in terms of the intervention itself, and we won't see the impacts for, you know, probably really another 6 months to a year before we begin to really pick these things up in our data.
Hi, I'm Trish Livingston. I'm the Director of Quality and Efficiency with the Ministry of Health.
Trish.
Can you hear me okay? Hi, Gary.
You bet.
Hi, and Saskatoon crowd. I just wanted to make a couple of comments too. Certainly, like, these are just new results coming into us, but we have, you know, really been impressed with what we've seen over time happening with this program. I agree, it's kind of definitely still in the messy phase. So we're starting to see that cultural change happen, and I think over time will hopefully impact the outcomes that we're hoping to impact in a more positive way. But certainly, you know, the cultural changes that have happened with nursing wards, you know, really focusing as teams on improving the care that they provide and, you know, reducing falls and medication errors, coming together to put up visual cues to help them so that they're, you know, to prevent them from making errors and things like that. That's the kind of cultural change that we're really after, and we're really starting to see on these boards. And I think, Gary, you mentioned it as well, putting the boards up and having huddles around those boards. I mean, those are big changes that we're seeing. Again, we know they're anecdotal, but you can see them with your eyes when you visit these wards. The thing about targets is, yeah, we haven't set those yet for the direct care time, and I think that's a discussion we have yet to have with HQC and with our health regions and everyone who's implementing it. The target we had set at this point was for implementation, to make sure that we get, you know, a large majority of the nursing wards implementing it and implementing it in as full as possible way. And so I know we're I get 90% now in terms of implementing this program in all of our medical and surgical wards in all facilities across the province. So that's a real big achievement to get everyone at least started on this path. And I think there's more to come and more that we can learn and help us to evolve this program to be even better than what we've seen come from it so far. More of a comment, not a question, Gary.
Thanks, Trish.
Thank you, Regina.
Sorry, we have a question from the boardroom here at U of R. Do you have time for that? Is that okay?
Yeah, we do. Go ahead.
Yeah, okay. I was wondering, what has the reaction from the doctors been to your program? Because I noticed that it's nursing-led improvement, and you focused on reaction and evaluation from the nursing community. What about from the doctors?
Wow, you're asking the wrong person. I got to get Kyle up here. Come on down. So Kyla Avis is the program director for the Releasing Time to Care implementation in the province, and she would be much more qualified than I to address that question.
Hi everyone, hi Regina. It's kind of a difficult question. It hasn't really formally involved physicians. I know depending on the unit, some physicians have been more involved than others. I think the nurses and the teams are always seeking the input and the feedback from the physicians as part of the teamwork that they would have to do anyways. They also involve dietary, housekeeping, physiotherapy, OT. So particularly around things like admission and discharge, we know that some teams have involved the physicians in that. But I know that from what we hear from the teams, is that it is often found to be a challenge to get the doctors involved, to sort of have them participate in the modules, probably because of their time and the work that they're doing. It's a bit of a challenge, but we do ask them to consider physician participation as much as possible, just like everyone else. And there have been some good feedback and some comments from the physicians to help guide the teams in their improvements. And so, you know, we often say to the docs, even if you can just provide some positive encouragement, that's really all that they need, if that's all that they can provide. So it's mixed, but there's a little bit of interest and expression of support from the physicians in Saskatchewan for sure.
Thank you very much.
Thank you. We have time for one more question.
Yeah, they've had it going in the UK for probably about 4 to 5 years, and it's variable, but certainly within a year, people have been reporting changes in patient outcomes. Now, one of the things that's really interesting that you know, hindsight is 2020. When we imported this program from the UK, we were hearing all of the reports from the local. In fact, we did a visit and took quite a number of senior leaders and union leaders and others over to Britain to see it firsthand and to visit wards that used it to get a sense of what it was like and what difference it was making. And the one thing that we maybe didn't think about enough was that Britain has a very strong electronic medical record infrastructure in place to do that local measurement at the front line and to support the staff in feeding back that information about how they're doing on patient outcomes and some of these other things, which we don't have here. And so that has been a significant barrier. Now, we knew that going into this program, which is why the huge importance of the Sun government partnership around creating nursing positions for the measurement coordinator role to help facilitate measurement at the front line. But we don't have the infrastructure to support even those people to do their job well. So those are some of the challenges we're seeing. So they would be seeing changes, you know, within the first year in terms of patient outcomes and so on. We're seeing changes in terms of the unit environment, certainly within the first year. We're harder pressed to get at the patient outcomes piece because we don't have a good systematic way of measuring it. Some of the units have created their own measures, and I believe we're starting to see some changes locally, but currently there's no standardization of those measurements across the units. And you know, we actually did consciously make the decision not to impose a set of standard measures, and you know, we might in some senses kick ourselves for that afterwards, but our priority in doing this was that it was about the culture change and the engagement piece. And if we were too much top heavy in terms of saying this is what you need to do and this is what it has to look like, it would just look like every other quality initiative and every other top-down thing that's ever come along. So very consciously we said, okay, we're going to suffer for this in the sense of being able to capture outcomes, but we're not going to tell everyone what they need to measure and how frequently and where to report it. And now, you know, as of this summer, the conversations are happening amongst them. They're saying, gosh, you know, we actually need to really come up with a standard falls definition. We really should standardize how we're measuring infections and the various things that we're trying to impact on. So that conversation is actually coming from the front line as opposed to being told to them, which is really powerful. Now the challenge is for the leadership and Health Quality Council and the regions and so on to hear those voices and build the support that they need. Thank you all very much for your questions. It was delightful being able to present. I know I went a little bit over time, but it's been a joy today. Thanks.
Thank you everyone for coming. It was a great talk, and enjoy the rest of your day. And one more time, let's thank Gary for coming.
Good, thanks, Robert. And just as we go, to let you know that the next in our WRTC seminar series will be next Friday, that's September the 30th, and it will originate from the University of Regina, but we'll be here, and Dr. Jerry Hurley, who's with the Department of Economics and Centre for Health Economics and Policy Analysis at McMaster, will be here talking about Ontario primary care physicians and pay for performance incentives. So we welcome you to come.